A headache is a pain in your head or face that's often described as a pressure that's throbbing, constant, sharp, or dull. Sources of headaches and management of pain. Tonight, On Call with the Prairie Doc.
Welcome to On Call with the Prairie Doc, health information based on science, built on trust. I'm tonight's Prairie Doc host, Dr. Debra Johnston. Thank you for joining us as we learn more about headaches. Headaches can be caused by a variety of factors, from lack of sleep to serious underlying medical conditions. While most headaches are not serious and can be managed with over-the-counter medication or lifestyle changes, there are certain situations when medical attention is necessary. It's always better to err on the side of caution. Seeking medical attention for new or unusual symptoms can help ensure that underlying medical conditions are sought out and treated. Tonight we will discuss headaches, causes, prevention, and management of pain. Thank you for joining us. Your questions guide our discussion. This evening, we are joined in the studio by Dr. Jeffrey Boyle from Avera Medical Group Neurology in Sioux Falls, and via Zoom by Dr. Leah Thronaum from CentraCare in St. Cloud, Minnesota. Welcome, and thank you guys so much for joining us this evening. Dr. Boyle, I'm going to start with you. Tell us about yourself and how you ended up in neurology.
Well, I was always interested in the neurosciences and how the brain worked, and I really liked seeing patients in medical school, and really needed that face-to-face interaction. So neurosurgery was not on my plan, and so headaches are just part of neurology. My mother and sisters suffer from migraines. So I had, I remember when I was 4 years old, my mom would just want me to just squeeze her head, and that helped her get through her headaches. Now we have a lot more options for treatment than just having your 4-year-old
claw your head.
Yeah, try and help with that pressure. But yeah, that's kind of how I got into it, and yeah.
Dr. Thronaum, how about you? How did you come to do what you do, and what is it that you do? We didn't tell our viewers that.
Yeah, no worries. So similarly, I kind of knew I wanted to get into this area. In fact, I thought I wanted to be a neuroradiologist when I started med school, but soon realized that I would go a little crazy if I had to be in a dark room by myself a lot. I have a sister that really struggled, that's quite a bit older than me, and I kind of saw that impact that it had on her life, especially as she moved into her career and had children and all of that kind of thing, how it trickled down in so many aspects. And so really, the lack of help out there and the lack of understanding out there kind of prompted me to go that pathway as well. And so I oversee a headache center. It's comprehensive, with a lot of integrated care. We do a lot of different procedures. From pharmacologic to non-pharmacologic management, kind of do the whole shebang.
So you're the real specialist in headaches. We've got the primary care, the neurologist, and the headacheologist. I don't know, is there a term for headacheologist, a technical term?
No, but I like it.
Yeah, well, there you go. Here we've coined it on Prairie Doc TV, headacheologist. I like it. Before we start our conversation, we invite you, our audience, to submit your questions for tonight's discussion about headaches. Viewers can contact us 3 ways. Call 1-888-376-6225, send an email to ask@prairiedoc.org, or ask on our Prairie Doc Facebook page. We will work to answer as many of your questions as possible, given the time available. Sometimes we receive more questions than we can cover, and we apologize if we don't get to your question. Your question will remain anonymous, and no information is saved. You can leave your name, email, or phone number and be entered into a drawing for our Prairie Doc publication, Perspectives from the Prairie, but it's not required to submit a question. The winner will be drawn and announced at the end of the program. So we talked just a little bit, I mentioned in the intro, that some headaches are dangerous. And what, Dr. Boyle, would be some of the warning signs, some of what we call red flags, that would tell us that this is a headache that needs attention sooner rather than later?
I think the number one concerning thing about a case, or feature of a case that comes in, is if there's a neurologic impairment. So a person.
What does that mean?
So weakness, numbness, clumsiness, vision loss, double vision, something that's coming, sometimes slow in onset, and it just kind of develops, and you say to mom, I think your speech is slurred, when you see her at Christmas, or it wasn't like this on Thanksgiving. And so, that's the most concerning thing. Many forms of headaches, many different kinds of headaches cause blurry vision. And so if there is a visual change, if you see your eye doctor and there's something wrong that the eye doctor mentions, usually they'll refer you to a neurologist. We have a lot of relationships with optometrists and other eye doctors, and so we get the referrals from there. But go see your, if your vision's changing or something wrong, go see your eye doctor. I mean, I think that's a real easy thing to do. So,
Dr. Thronaum, what do you have to add?
Yeah, no, I agree. I mean, anytime you have some kind of what we call nerve deficits that needs to be checked out. I guess the other thing that comes to mind, or like two other things that come to mind, are something that we call like a thunderclap headache, which is just sudden severe onset of incredible pain. And then anything that's new and around pregnancy, to me, it would be another one of those areas that, someone may have a history of migraines, but if something is new or changed or significantly different, that should always be looked into a little bit further.
And I always think fever. As a primary care doctor, I always think about meningitis as a cause of headache, or encephalitis. We were talking a little earlier tonight about West Nile, and how West Nile can cause encephalitis, and that can cause a headache, and that's obviously something you don't necessarily need to be trying to treat at home. Yes. Not that there's great treatments for West Nile, but other sources of encephalitis and meningitis there can be, and it can be very devastating if you don't get that treated ahead of time. So Dr. Boyle, when you're looking at a patient who's coming in to you with a headache, and you're trying to tease out what is causing this headache, what are the kinds of questions that you ask that patient that you want to hear from them to help you figure that out?
So it's a story. I mean, every medical evaluation, needs to kind of start at the beginning. And so when did symptoms start? Some people say, well, I've had headaches all my life, or, but if the headache in, 60 or 70-year-old person started last week and nothing, caused it, then, I need to kind of know that. It changes how I think about that person versus somebody who's 70 years old but has had headaches for 50 years. And so where the story starts, and then really how it's the characteristics of the headache. So is it on one side? Is it pressure-like or throbbing? Is it occurring during specific triggers? Is it occurring at specific times of the day? And then is it coming along with other neurologic symptoms? Many people with migraines will have an aura, kind of a pattern of kind of like this pattern on the wall of our studio here, but it's like a specific pattern that they see. And so if they have those symptoms, or if they're light sensitive, those are going to help me figure out the right treatment pathway to go down. So,
Dr. Leah, are there different types of migraines that people can get?
I mean, everyone kind of describes their headaches differently. I think everybody likes to try to fit things into one nice, neat category. You know, this is my migraine headache. This is my really bad headache. This is my tension headache. This is my after work headache. This is my weekend headache type thing. But a lot of times it comes down to is that a lot of times they're all the same headache. The way people describe them can be different depending on the symptoms they're having. So every headache does not need to manifest the exact same way, right? But it still can all be the same category of headache, if that makes sense.
Mm-hmm. Mm-hmm. Absolutely. So that's something that people don't always realize is that, gee, yeah, I know you get these migraines where you get this funky thing in your vision and then you've got to be in the dark room or you start throwing up and you can't get out of bed. But maybe that sinus headache that you get on a real frequent basis, maybe that's actually a variant, a version of your migraine headache. And, maybe all that Zyrtec isn't doing you as much good as you think it is.
Absolutely agree.
Yeah.
I mean, honestly, most sinus headaches are actually migraines. A true sinus headache is related to a bacterial sinus infection that resolves after their course of antibiotics. So, you can get what feels like a sinus headache, getting that pressure in the front and in the sinus areas and in the nose and forehead, and even sometimes where you get a little bit of T-sensitivity like you get when you have a sinus infection. You can get the stuffy and runny nose and all that stuff with migraine. But what it really comes down to is, unless you have a bacterial-related sinus infection, it's probably a migraine.
Yeah. And so I think that's a really important thing because a lot of people come in and they want their antibiotic because they're sure that they've got a sinus infection, and it doesn't always go over very well when I tell them, I don't really think this is going to help you. Sometimes they've got to experience it, but then their headache gets better because migraines tend to get better, and then they think I was wrong. And of course I wasn't.
That's a hard thing to convince, right?
Yeah, right, absolutely. So what is a common presentation of a migrainer? What might you hear in that history that clues you in? We've talked a little bit about that, but yeah. Who's a common migraine patient?
Well, the other feature I haven't talked about, I'll ask about family history. So if it runs in the family, then mom had it or dad had it, and then you get a headache in your 20s. It's really bad on one side and kind of throbbing and with nausea and vomiting. That kind of goes along with migraine. I think that migraine kind of transforms. Some migraines, especially for women, are hormonally related, and so sometimes at that change of life in like the late 50s, that the headache changes. Sometimes it goes away. My mother was blessed, and she no longer has to experience those. But some women, it's more of a chronic headache that it's not on one side anymore. It's like more frontal or. And it's more common. It's not related to a time of the month. It comes up with sleep deprivation or a trigger in the diet that they have, whether it's chocolates or red wine or other alcohol. So those are some of the things I ask about when I'm thinking about a migraine and trying to evaluate it. I like to really ask a person, how is this affecting you? And some people say, well, I get it once a month. It's really bad. I throw up and then I go to work. And other people say, well, I get a headache almost every day. It's mild. I can still function, but then I'll get a really bad one a couple days a week. And so every patient's a little bit different, and that evaluation and then management has to be kind of tailored for that patient.
Dr. Thronaum, what are other common triggers for migraines?
You just froze there for a second. So you asked what are the common triggers?
Triggers, right. What might provoke a migraine for someone? Yeah,
so again, everyone's unique, right? And what triggers one person, is going to be different than another person. I mean, you could be identical twins and still that's going to be the case. I mean, the migraine brain is basically a sensitized brain, and so it's kind of always sitting at the edge of that cliff. And what can what will tip over a migraine patient won't tip over someone without migraine. So sleep deprivation is a really common one. You know, none of us are going to feel great if we get a crappy night's sleep, but you know, we're probably not going to tip into migraine territory, and that could be a common trigger. Food can be a trigger for some people, but food is probably one of the harder things to identify. There's some common ones that are well known, like alcohol, especially darker alcohols, and MSG, as well as aspartame. So diet sodas, that kind of stuff, really, really common. Otherwise, you know, food triggers, I think they're highly emphasized, but they're harder to identify. Not a big pusher of diet elimination diets with headache patients. That's really hard to do, and not usually sustainable either. Hormones, you know, as Dr. Boyle mentioned, estrogen drop off. So it happens like right before our period. That is really very, very pro migraine, and kind of as he was mentioning around menopause, perimenopausal time. You know, we have a lot of fluctuations. So estrogen's going up and down and up and down, and those big swings are incredibly pro migraine. And so people with a history of migraines tend to struggle during those periods as well. Likewise with pregnancy, about 2/3 of patients do better, especially after the first trimester, because while hormones are all kind of elevated, but they're even kill elevated. So that's another big trigger.
I always think about stress, travel, altitude changes, barometric changes, things that maybe aren't quite so obvious, but that I've myself noticed can be a trigger for me. So, you know.
Barometric pressure and weather changes, that's the tricky one though. It's a really common one, but unless you're willing to move,
yeah,
you know, it's really hard. It's really hard to pre-manage that.
Yes, absolutely it is. But sometimes it's helpful to have an explanation. So. Navigating a migraine can be difficult. Prairie Doc spoke to Bill Hayes, an ambulatory care pharmacist and professor at SDSU, about the various aspects of migraines.
People who struggle with migraines should also keep a journal to help document more information about their migraines, which can help when dealing with them. Things to write in the journal include food consumption, environmental factors, and activities.
We see migraines affecting females far more than males. And then when I present this to the students, they're always kind of like, you know, that's most of the topics I have, females have a little bit more higher incidences, but I always counter with that third type of headaches that we see, those cluster headaches. Guys are more likely to have those and have to manage cluster headaches. But migraine headaches are predominantly females. And again, those are averages. I've met a lot of guys with it. I've met guys that have been diagnosed with it.
There are several medications and regimens to cope with migraines, but each is very patient-specific.
The first thing we think about is how severe the headache is. Is it like just a minor annoyance? You know, those patients are very lucky, blessed, where, you know, there are patients that can get away with just taking a simple analgesic like an ibuprofen, acetaminophen, and, you know, maybe going home from work, you know, seeking a dark, quiet room. But typically, the average presentation is going to be more of a moderate to severe and debilitating, where the patient's going to have to leave work or, you know, leave class, go to a dark, quiet space until the headache is gone. In those patients, you know, we have two treatment options. You know, beyond the non-pharmacologic, you know, seek a quiet, dark room, sleep. We have treatments in two different kind of buckets. We have prophylactic or preventative. So we take something every day to avoid migraines in the future versus an acute.
Health professionals are learning more about migraines and how to relieve them.
I think as we move forward in the next decade, 2 decades, we'll see hopefully a greater understanding of the pathophysiology behind migraines.
So, Dr. Leah, how long should someone deal with migraines before they look to get professional help?
So I think if someone is being affected by headaches, even severe ones that are affecting them 2 times a month, that are knocking them out of work, knocking them out of school, knocking them out of life, they should be talking to someone about it, because that's a lot.
Yeah. You know, if your Tylenol takes care of it and you can get back to your life and it's not happening very often, great. If it's interfering with your life, let us try to help you. That's what I feel about it. So, all right, we've got some good questions coming in here. So this one's not about migraines, but that's good because there are other kinds of headaches. This individual says, what is a new daily persistent headache and how can it be treated? Dr. Leah, I'm going to throw that one to you.
Yeah, so new daily persistent headache is exactly what it sounds like. I mean, these patients, they come in, they all of a sudden, they wake up, they have this headache. They don't really have, a lot of times they don't have a history of headache, although sometimes they do have a history of migraines, but they can really pinpoint it down to the day that it all started and it never kind of went away. Most of the time we don't have an underlying cause, just like all the other primary headache disorders. It's one of those things that just kind of is. A lot of times at least for myself in personal practice, I have seen it kind of been associated with post-COVID types headaches, post-viral type headache syndromes, things like that. You know, the syndrome's already resolved itself, but they're kind of left with this ongoing persistent headache.
So what can be done?
So kind of addressing some of the underlying root lifestyle things is a good place to start. But I mean, there's medications that we use to target and treat these, and they're commonly across the board kind of used for a couple different type of headache disorders, and including post-COVID headaches and post-concussive headaches. They can all kind of work similarly and can work fairly well.
Good to know. All right, Dr. Jeff, would cutting out alcohol help with my headaches? I get them about once a week, but they're not severe. What would you tell this person?
Well, I sort of prescribe to a threshold effect with many neurologic conditions, and headaches certainly can be one of them. And so if a person says, well, I really like, scotch or red wine, and it doesn't always correlate with a headache, then I say, well, you can address maybe other things, and if that's really, that practice of consuming red wine with your steak is something you really enjoy, well then, focus on, stress management and sleep, and then maybe you can still, have a glass of red wine. But if you're having migraines the next morning every time you have a glass of red wine, that might be a strong trigger, and you may always get above that threshold to trigger a migraine or trigger a headache when you drink it. So it's, for some people that are just really suffering, I will say, all right, you have to do all of these things all at once and get yourself to a nice place where you're not getting, debilitating headaches. And then I say, pick something to reintroduce. And if you say, well, that glass of red wine was well tolerated, well, then that's probably okay.
So you've got to decide which of all your triggers you're willing to add in or get rid of altogether.
Some people, yeah.
Dr. Leah, how about caffeine?
It's a tricky one. I mean, you could be hard pressed, someone that loves their coffee, not to convince them not to drink their cup of Joe in the morning. I would go with Dr. Boyle that everything's in moderation, right? Caffeine is okay, but doing too much of it, energy drinks, high levels of caffeine in 1 ounce or one sitting, also can cause headaches. So there's a fine balance. Some people swear up and down by, getting a shot of espresso when they start getting a migraine, and that can help. There's some evidence that supports that. But again, is it the mainstay of treatment? Absolutely not.
All right. Here's a viewer who says that she is perimenopausal, and every month she gets a tension headache now when she didn't get them prior to being in perimenopause. What can they do to help with this every month? Dr. Boyle?
Well, so tension headaches, I feel like they're, you know, a lot of stress management. You know, stress is just, you know, it manifests in our face and our shoulders. We're a social creature. You know, we communicate. When I get home from work and I walk in the door and I've had a bad day, my face looks tense, you know, because I'm dealing with the stress and I'm emotionally carrying that. And my wife will say, "Oh, are you okay? Did you have a bad day?" And that's where I think, you know, tension headaches kind of rest. And so, yeah, we can use muscle relaxants. I mean, I don't prescribe them very often for tension headaches, but I really try and address that underlying cause for tension. And then, you know, if we're not getting very far with, you know, some non-pharmacologic sort of strategies, and somebody's really suffering, then there are medications that we can use to kind of help.
What else should this person think about, Dr. Leah?
So my first question would be, if she never had tension headaches in the past, was she a headache person in the past, and are we sure that they're tension headaches? You know, outside of, you know, as Dr. Boyle said, are there other influences that are happening, other stressors, other lifestyle things that are changing? You know, someone that's perimenopausal, is their sleep being affected because they're, you know, having hot flushes at night? And that's could be a very big factor. You know, is that what's being a trigger? So I guess it would come down to kind of getting a little more history about that, and trying to isolate in really what we're dealing with, because, you know, if it's headaches and or migraines and it's related to hot flushes or sleep related to that, you know, there's ways that we can manage that.
This would be someone who maybe would want to not try to manage this at home, but go in and talk to someone, and let's figure out what we can figure out about what's underlying all this. Here's someone who's wondering if chronic headaches can be inherited. Dr. Boyle.
Well, I kind of mentioned earlier that migraines certainly can run in families. You know, other than that, the major headache syndromes, you know, not really. I think that people will adapt strategies for coping with stress that they learn from their parents, and sometimes maybe they're not as good as others. And so then, you know, so tension headaches can run in families, but maybe they're not genetic. But chronic headaches develop over time. I feel that they usually start as episodic headaches, and then they sort of evolve into more common, you know, almost everyday kind of chronic daily headaches or chronic headaches. And so, yeah, coming in and getting evaluated, and I think that's still quite important. And yeah,
absolutely. Dr. Leah, I am going to rephrase this question a little bit because I think that this is, we need to approach this a little different so that the caller understands this. Why do neurologists not give morphine to migraine patients?
To treat their migraine?
To treat their migraines.
Well, I think one of the biggest reasons is because we have a lot better medications that are exceptionally well targeted. There's a lot of things that are happening in the brain and lots of different areas that are involved and get triggered with a migraine. And we have medications that can really target in on those specific areas to counteract what's happening. Morphine is not one of those medications, nor are any of the other narcotics. And while it may dull the effects of the pain itself, it's not actually stopping the process from happening. So that entire cascade is still continuing, and they're likely going to get what we like to call the post-drone symptoms as well. So that continued just hangover phase, if you will. So I think that's one of the big reasons, not to mention the fact that there's a high risk for abuse, as well as rebound and medication overuse headache when we get into using certain types of medications like narcotics and the butalbital containing products.
Anything to add to that, Dr. Boyle? No,
I absolutely agree. the more powerful medications have their place. So if you have surgery and need a narcotic to kind of get through the night and start the recovery phase, using it overnight after a big surgery is probably quite appropriate. But a person that has a migraine once a month, or a really bad tension headache, the potential for abuse is there, and so you start using it more and more, and then you become tolerant to it, so you need higher doses to get the same effect, and then you become dependent on it. So if you stop taking it, then you feel withdrawal symptoms. I mean, these are for me as a physician, do no harm. I mean, I recognize these medications can help a person in the short term, but in the long term, what are they going to look like in a year? I mean, if I start them on something that can make them dependent on it, and then they need more and more of it, it's kind of a slippery slope. So I prefer not to use these medicines that have those features in them.
And I was always taught that the opioids actually reinforced the headaches and would worsen the headaches over time. Is that still current thinking, or is that my 30-year-old medical education speaking?
Yeah, I would say, there's a likelihood of getting into that rebound phase and getting into that medication abuse headache phase. And honestly, for me, and I would say as well for patients, those are by far the hardest headaches to treat, because we really got to get out of that phase before we can tackle well and get somewhere with their underlying headache disorder.
And I think that is a great thing for us to keep in mind as we go to our next roll-in. Migraines affect millions of people worldwide and can affect your work and home life. Interventional pain specialist Dr. Tyler Tachek, talks about migraine symptoms, medications, and treatments individuals can use.
Migraines are different from headaches.
And I typically use an acronym called PIN, P-I-N. And if there's photophobia or phonophobia, so if there's sensitivity to light or sound, if there's intractability, meaning it's going to be there for hours or days unless you do something, and if there's nausea, then it typically is a migraine or a migraine variant. Typically, it's required to have 2 out of those 3 positive. So if 2 of those 3 are present, it's a migraine. Plus, migraines are very debilitating. So they're moderate to severe pain. Oftentimes, when you get a migraine, you can't do anything. Can't go to work, can't go to school. You basically have to lay down in a quiet room.
There are treatments and medications specific for migraines compared to normal headaches.
I would say we have a pretty decent revolution in the treatment of migraines with the advent of the CGRP blockers. Those are typically an injection that you would do once a month, and it prevents the CGRP molecule from actually working. Those are what we call prophylactic. So those are something you do if you have migraines or headaches associated with migraines for more than 16 days a month. So most of the time you're having a headache, you can just prevent them. Sometimes patients take more of what we call the old school medicines. So you can take medicines that slow your system down, like beta blockers, that decrease your heart rate and they just decrease your whole system. We have a lot of membrane stabilizers like topiramate or Topamax that can help with migraines. And then amitriptyline is a neuropathic medicine that a lot of patients take at night to prevent them. Typically, when you have very few migraines, you wouldn't focus on taking a medicine every day to prevent them. You would take something like a triptan. Triptans work because they close the blood vessels down in the brain. So we know if the blood vessels aren't opening up from that chemical, if we can counteract that by closing them, they can decrease how long the migraine lasts for.
Genetic components also play a role in who gets migraines.
There is a genetic component. So we ask every patient, do you have any family members who have migraines? Do you have, did your mom and did your grandma? There's more of a predisposition to pass that through the female side. I would say that it doesn't really change our management, but it does clue us in, like, yes, this is a true migraine syndrome.
So before we heard from Dr. Tachek, we were talking a little bit about rebound headaches, and I think that's our medication overuse headaches, and I think that's an incredibly important topic for us to talk about. Dr. Leah, what is a medication overuse headache?
Yeah, so to be perfectly honest, there's also a lot of debate in the headache community whether medication overuse headache actually exists. About half the people are on the side that it does, and half the people are on the side it doesn't. But that being said, I'm on the believer that it is a real thing. So medication overuse headache basically is when you get an increased number of headaches, and they are less responsive to acute treatment medications, and they just keep coming back, and they come back stronger, and they don't go away as easy. And it can occur if you are, typically what I tell patients is no more than 2 days out of a week do I want you really using something that's an acute treatment, and that includes over-the-counter analgesics, so like your ibuprofens, your Excedrin migraine, and things like that. So if you're doing that for over 3 months, you can get into rebound headaches. For the MOH. But that isn't always the case. I mean, it doesn't always have to be that infrequent. Sometimes that can occur with as few as 4 treatments with certain types of medications, including narcotics and the butabitol containing medications. So there's a difficult cycle to get in or to get out of once you're in it. And anything that we can do from a preventative aspect to keep people out of that, which is where preventative stuff comes into really big play. We got to cut down the number of headaches so they don't feel like they need to treat that many.
Anything to add there, Dr. Boyle?
It is very frustrating to physicians, to neurologists, to try and help folks, because it is, they're using these medications for the headaches, and I feel like at best can treat the underlying headache, whether it's tension or migraine or stress headaches or ocular headaches, and so I need patients, to kind of stop that cycle, and then they kind of, the underlying headache, which isn't as frequent as the medication overuse headache, that kind of emerges, and then you can really help them.
So you're on the yes, I believe that it's a real thing side of the of the equation too. Yep. All right, and here we have a caller who says that they changed birth control pills and now they're getting headaches. Could this be the cause, Dr. Jeff?
Certainly something to consider. It's the change in estrogen that goes up and down with a healthy cycle. That certain of these hormonal contraceptive pills, some of them control those hormonal swings better than others, and it's complicated between estrogen and progesterone, and then how it's taken, and then the dose. So that complexity is something that I think people have to kind of individualize. And if you're getting headaches after this event happened, like a new medication, then talk to your doctor about maybe switching back or trying something else.
Talk to your doctor, always a good answer. So we are getting lots of questions, and we don't have a lot of time left, so we're going to have speed rounds, guys, okay? Here's somebody who says they get tension headaches from sitting at their computer, and they stretch and move, but they still seem to get them each week. What can they do to prevent them? Dr. Leah?
Ergonomics. One of the biggest things. Yep. So, how you're sitting at your desk, if you can have a sit-stand desk or some kind of screen like that, a lot of it comes down to ergonomics. That's in yoga, do yoga. There's lots of research showing that can help.
So PT assessment for an ergonomic adjustment might be right in order. Here's someone, actually we have a couple of questions about this. Botox for treating migraines. Dr. Jeff.
It's fantastic. It's not first line, probably from the expense, and then it's, there's a lot of injections over the head and neck, but it is fantastic in my experience. If I had to pick one therapy that I could use for the rest of my life for headaches, that would probably be it. But you can't have every patient just start on Botox. You need to figure out what kind of headache they have, and then it's really for migraines, chronic migraine headaches that are pretty common and pretty debilitating. But
do you like it too, Dr. Leah?
Botox is fabulous for the right patient. There are some insurance companies that are not making us jump through all the other preventative trial medications, which is it's kind of nice now. They are looking at it being more first line, which in my mind it should be. But yeah, I mean, the caveat with Botox is a lot of times you have to give it, getting in the second round before it starts working. It's repeated every 12 weeks, but once you get past that threshold, it tends to work insanely well for patients.
How about trigger point injections or occipital nerve blocks? Dr. Boyle.
It's a very useful tool in the right patient. You can sort of break a cycle where the muscles become tense, they sort of get strained and they hurt, and then they're hurt so they get tense. And so you're in this cycle, and so I like, ideally, the patient in that cycle, you have their physical therapy sort of set up, or massage, or some type of physical therapy modality, and then you do those injections, and then they use warm compress, and they're really working on the muscles, and they go right to physical therapy within a day. And I think that helps just break the cycle. The medication I use for trigger point injections is just an anesthetic. So, they're numb.
Like the dentist would give you.
Kind of like what the dentist would give you. And it's going to wear off after a while. So if we want to sustain that effect, something else is going to be needed. So sometimes it's just kind of working those muscles and trying to release the tension a little bit.
Here's someone who wants to know about auras. They had one last month and had never had one before. It went away in about 20 minutes. Dr. Leah, what's an aura?
Yeah, starter patients get auras. And the aura can be, most commonly, people describe a visual aura. And that can be a variety of different things. It can be like a growing dot. It can be little shiny little shimmery lights, or a kaleidoscope view. And they typically last anywhere from a couple minutes up to about an hour. But you can also get other types of auras, problems with your sensory. So, numbness or tingling in your face, arm, like things like that. Difficulty with your speech, weakness, that kind of thing. So there's a lot of different types of auras, but basically they precede the onset of the headache. Typically don't last any longer than an hour. It's a good warning sign for patients that get an aura to adjust and take their abortive medication, their acute medication at that time, and try to bypass the headache phase as well.
We've talked a lot about migraines, and here's someone who is wondering about cluster headaches and how they can get treated. Dr. Boyle.
So cluster headaches are kind of a cousin of a migraine. It is a severe headache that runs in clusters lasting weeks to months, and they're quite severe for these patients. One of the things that amazingly works is high flow oxygen, and so you can give oxygen to these folks, and they do pretty well during that cluster. And there's other strategies that we use to try and prevent that cluster, during the headaches during the cluster. But yeah, it's just it needs to be evaluated, and there are definitely treatment options that work for a lot of folks.
These folks are usually so miserable that there's no question about whether they're going to come in and see somebody or not. It is a terrible, terrible condition. Here's someone who says if they have to cough several times, they always get a headache after it. Is there anything they can do to prevent this? Dr. Leah.
So this is one of those situations that maybe just what we call one of the primary headache disorders, right? That there's no underlying cause, but it's also one of those things that should be evaluated for a potential underlying cause as well. And typically with just some imaging done, we'll answer that. But most of the time, it's, that's going to be normal. And if it's every time that they cough, they get this headache, then there's medication that you can use specifically to manage that. A medication called indomethacin that's used for primary cough headache, which is an actual diagnosis.
Yeah. So maybe this person has learned something new and they can go talk to their doctor about it, and go talk to their doctor anyway to get it checked out. This individual says they had a concussion last year and was cleared by their doctors, but sometimes they still get headaches since having it. Could this still be left over from the concussion, and should they be concerned? Dr. Jeff.
Well, post-concussive symptoms, they resolve with time. And so if somebody has a concussion and a headache, and that persists for a week, probably the concussion, a month or 3 months could be the concussion. But I've had patients that never had a headache and then they get a concussion and they still have headaches, a year or 2 years later. At some point, I stopped treating them as a post-concussive headache, and I think that maybe it triggered some other headache syndrome like tension headache or migraine headache. And so it's really up to the clinician to kind of reevaluate a patient that's coming in regularly and having these symptoms. And at some point, if something isn't working, then change it. But it still could be some, a headache syndrome that was triggered by a post-concussive symptoms, and then now it's transformed into something else.
So get it checked out.
Yeah.
And especially if it's interfering with your life. If it's not interfering with your life, that's maybe a different story.
Some Tylenol.
Some Tylenol, but not too much,
but
and not too
much.
often.
Right. No more than 2 days a week.
So this person says that they have TMJ and they have a mouthpiece, but sometimes I still get a headache. These seem to be really hard to get rid of. Any advice for that type of headaches?
Yes.
Go for it, Dr. Leah. Go for it. Speed round.
Speed round. So physical therapy that's targeted specific for TMJ can be incredibly helpful. Also, Botox can be incredibly helpful for those patients that are kind of refractory with getting those muscles to loosen up.
Perfect. I love it. Great speed round. Here's one. I use a CPAP, and when it moves around, it always gives me a headache. How can they keep that from happening? Dr. Jeff, with your dual-headed neurology and sleep medicine, this is a great question for you.
And really common, unfortunately. So some people with that neuralgia, that occipital neuralgia, the strap hits their nerve, so you have to kind of think about that. Sometimes it's more tactile in the face, that the leak, blows into their eye and gives them eye strain, and so it's. And then some people that take the mask off at night, and then they're low oxygen and they're high carbon dioxide by the morning, and they get the morning headaches. And so it's kind of, there are many ways to get a headache, with sleep apnea and with, a CPAP machine or a mask that doesn't work. But, trying different masks is the key. If a mask goes over and doesn't hit that nerve as it goes over this, this ridge on the back of your head, maybe that would do the trick. Or maybe a really good seal, because some people have a really high bridge on their nose and they need a different kind of mask. These are all things that they have to kind of work through.
Would this be a person that might consider Inspire, the surgery for sleep apnea?
Yeah, and I have patients that say, I can't wear a CPAP mask because every strap just hits a different part of my occipital nerve. And so, the Inspire is no mask. And it works really very well. It's
for the right patient.
For the right patient. It's a second-line therapy. It's not as good as CPAP, but if you don't wear CPAP, it's not very good at all. So the Inspire is a good option.
Dr. Leah, here's someone who wants to know if there's anything different about treating a migraine where the pain radiates from the top of the head. Is that the same treatment options as you get from migraines in general, or is there something unique that could be for that person?
No, the management really is the same. Where it originates from and where it radiates to. Jeff had mentioned a couple of times about the occipital nerve, as he was just mentioning, that can be a common source, but the whole pathway with migraine triggers lots of different areas, the head and neck. So it ultimately you treat it the same.
All right. And I think this is a really good point for us to emphasize here. When do I know that a headache is serious enough that I should go see a doctor? Dr. Jeff, I'm going to start with you.
Sure. We mentioned earlier it affects your life. The aura, we talked a little bit about that too. The aura can be quite scary at first. Certainly if it happens the same way every time, you don't have to be too worried. But really any new onset headache that's like just severe, you can't get out of bed, I think I'd probably recommend that you be evaluated. Those neurologic symptoms that somebody has and develops, and just go in and be better safe than sorry, really.
Dr. Leah, 1 minute. Anything to add?
Yeah, that's pretty spot on. I think the only other thing I would add would be, if someone says something to you like, God, it seems like you're having a lot of headaches. A lot of people, we just go through our life and we're coping, we're living, and we're, having to get through, and we're carting kids here and there and doing all those kind of things. And so we just do, right? So I think that's an important thing to pay attention to. If someone's starting to comment about stuff, then maybe it's worth mentioning.
Yeah. If it's impacting your life,
Yep,
let us see if we can help you. Absolutely. And if it's sudden, a big change associated with other scary symptoms, don't wait. If you have a sudden onset of the worst headache of your life, go to the ER. If you have a sudden headache that's associated with not being yourself, go to the ER. If you have a sudden headache and you can't bend your neck and you're running a fever, go to the ER. And otherwise, come see one of us.
Exactly.
Our winner tonight is Sean. A book will be sent to you shortly, and we'll be back after this.
Grab a copy of your local newspaper or read online the Prairie Doc Perspective, a weekly health and medical column. Head to prairiedoc.org to access all archived columns today.
Thank you to our guests, Dr. Boyle and Dr. Thronaum, for volunteering their time to help us learn more about headaches. If you would like to see and hear more episodes of this program, please like and follow us on Facebook, Instagram, Threads, YouTube, and TikTok, or visit us at prairiedoc.org. Look for Prairie Doc Perspectives in your local newspaper and online. Listen to us on Prairie Doc Radio on South Dakota Public Broadcasting Sundays at 6 a.m. and 1 p.m. And be sure to look for the podcast of this program, Prairie Doc On Call, wherever podcasts can be found. From all of us here at On Call with the Prairie Doc, thank you for joining us for another episode of health information based on science and built on trust. Until next time, stay healthy out there, people.
Grief is a normal human process of adjusting to changes and loss. It is experienced in so many ways. Support through grief, the importance of hospice and bereavement care. Next time, On Call with the Prairie Doc.
My name is Jennifer May, and I serve on the Healing Words Foundation Board, the nonprofit that runs the Prairie Doc programming. Our mission is to enhance health and diminish suffering by communicating useful, science-based information respectfully and compassionately. Your donation supporting Prairie Doc programming makes an extraordinary difference. Gifts of any size enhance its impact in our state and beyond. Thank you for your generosity.
Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello possibility. Hello healthy. Hello life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, South Dakota Academy of Family Physicians, Sanford Health, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health,